Hi, so this is going to be assignment 15.2. This is an educational tool for trauma-informed midwifery practice. So I have some notes and I'm just going to kind of go through like somewhat of a presentation. The basis of trauma-informed care is individualizing care for each person to take into account that most people come to us with trauma. So this is taking in their physiological history and every aspect of their history, which is important because this is like a pivotal moment in their lives. And the ability to individualize care to provide trauma-informed care that can improve health outcomes, reduce stress, and it can actually change someone's life. So a traumatic event is an intense experience or events that can happen over the course of a lifetime that have lifelong implications that cause stress, PTSD, difficulties in relationships, things of that nature. Traumatic stress is a type of stress that's related to a traumatic event. And that causes like anxiety, hypervigilance, depression, and some other symptoms. It can cause like major medical symptoms. PTSD is post-traumatic stress disorder, and that also has a variety of physical like ailments that come along with that, like depression, anxiety, panic attacks, insomnia, night sweats, flashbacks, things like that. So the 4 R's of trauma-informed care are realize, recognize, respond, and resist re-traumatization. You're realizing you understand what happened and you're acknowledging it. You're recognizing the signs and symptoms of traumatic stress. You're responding by having procedures or protocols that facilitate these responses. And you're going to resist re-traumatization by practicing trauma-informed care. So there's another principle. It's like 6 principles to trauma-informed care, and those are safety. You're implementing protocols to guarantee safety of clients, and you explain those to the client and to other people that you work with. Trustworthiness and transparency. You're creating those safety protocols and you're using shared decision making with clients to gain trust. Peer support, where you're creating a safe work environment with monthly meetings or whatever you feel like is necessary to create that safe work environment. Collaboration, being aware of the power dynamic between a provider and a client and using shared decision making, and then also vetting all your people that you refer to and making sure that they are trauma-informed providers also. And then empowerment, encourage healing and having clients have an equal part of their care. That can be a huge part of trauma-informed care. And then humility and responsiveness. This is allowing stereotypes and avoiding stereotypes and being educated on historical trauma, being open and responsive. If a mistake is made, you apologize, things like that, of that nature. So theories of intergenerational and historical trauma. I'm trying to like move along pretty quickly because I feel like this video could take a long time. I could sit here and talk about this all night. This is when you're talking about toxic stress in the perinatal period, which this toxic stress doesn't only affect the birthing person, it also affects the baby also. So when the body's put under chronic stress, it can be detrimental to their health. And there is a theory called developmental origins of disease, and that explains how a fetus can adapt to a mother's stress load, and that it allows for the fetus to survive, but it also, the trade-off is compromising the long-term survival. So the fetus could have a higher mortality and morbidity rate because of toxic stress on the birthing person at the time. So 5 moments where let me see where I'm at. 5 moments, distinct moments during the perinatal period that midwives can help disrupt these cycles of intergenerational trauma is, of course, by the initial consult, either by phone or in person. You want to use active listening. So, kind of repeating back to people what you think that you hear to make sure that you're hearing what they are saying. You just want to get more clarity. Ask people why they are seeking this type of birth. I love to ask that question, especially when we get a new client in, because I'm like, what drew you to this type of birth? And a lot of times that goes into storytelling. Like 9 times out of 10, I feel like if it's someone who's already had a birth experience, it leads into storytelling, and that will help us identify some trauma, past trauma, and what we could do to make this a better experience for them. Transparency, you always want to be upfront and honest, and especially if there's the possibility of a transfer at some point. You always want to make sure that these folks that may be coming into your care with trauma are aware that this might not be the best setting for them physically. Like maybe they risk out of the setting for some reason, so that's something that you always want to have like an open-ended conversation with, and the ability to go at that and like let them know, I want the safest place for you and your baby, and I will help you find a provider that will help you in the safest place. So like if that's a hospital, for instance. The next distinct moment would be interval prenatal visits. You're always going to want to set expectations for how your practice works. So we like to give a handout at the beginning of like prenatal care, like the initial appointment, where it explains each kind of like each visit. And of course they're not going to be at the exact timelines, but every 4 weeks, this is what we're going to do at this visit, this is what we're going to do at this visit. So there's nothing like blindsiding them, especially like, for instance, if they have trauma around needles or something like that, then they know, at their second visit, like, hey, we're going to need to do some blood work, so maybe you need a support person or something like that. Always asking for consent when you touch someone. I feel like that's a no-brainer, but not always, because I have seen midwives that just touch someone without asking, and that's just not a good way to approach someone. When you're requesting lab work and ultrasounds, like I was saying with that first handout we like to give, we set the expectations of this is kind of what we need from you to keep you low risk and prove that you're low risk. And sometimes that comes with some clarity about what the comfort level of the midwife. So for instance, where I work, my preceptor is comfortable with 1 ultrasound if someone's okay with that, but she does not allow people to not do any ultrasounds. And personally, I kind of feel like I'm probably going to be on that same page. I feel like there's things that definitely need to, now that we have the ability to have ultrasounds, we have the ability to like diagnose things before it's an emergency. And as a midwife who wants to keep everyone low risk, that's just a tool that's invaluable to me. So, you need to make that clear at the first visit, like this is what I kind of require, and if you don't want to do this, then we can do this, or things like that. And then make sure there's no barriers either to care, because another thing is like where I currently work, we have we were sending people out for labs, and we were sending people out for ultrasounds. Well, that tends to be a lot of extra driving, and gas is expensive, things like that. So now we've decided we'll do labs in-house, and I think that cuts down on some drive time and things like that. It's just more convenient. So you want to really make sure that there's no barriers to receiving the care that these people need. And then during the birth, you want to minimize the management as much as possible. Trust the process, and allow the client to lead with the least amount of interventions and interruptions as possible. Just provide a sense of safety. And then informed shared decision making, of course, is always going to be a thing. And then I just kind of notated, read the room. To me, that's a very big, it's a very good tool for a midwife to be able to have, is to be able to read a room. Personally, we have quite a few clients that are Spanish speaking only, and I don't speak Spanish, but I'm telling you, like, it's easy to pick up on what needs to happen and what people need, even when you don't speak the same language, as long as you're intuitive with what's going on. And then postpartum care, you're always going to want to try to do the golden hour, let them have the bonding time that they need with the baby. Be willing to stay if the client's not ready for you to leave, and then have a pretty reliable way to diagnose and assess postpartum depression. It's definitely a screening tool that needs to be always worked on. And then let's see, so I just want to make sure that I'm covering all the points that I want in this. Okay, so I'm gonna move on to PTSD. Sorry, I'm like looking through the check marks. I'm trying to stay on track here. So PTSD and midwifery can be quite a bit different. So sometimes you don't really know what the PTSD stems from. So you're having to approach every client with the thought that they may have suffered one or more traumatic events in their lives. We want to try to minimize traumatization and maintain safety for the client. So you really want to shift to past and current trauma exposure, reframe the way we view trauma, identify triggers, respond to them, and then recognize PTSD is intertwined with other issues. So you want to have very personalized care for these individuals that have PTSD diagnosis. You can't really just refer a client out with that has trauma or PTSD. They may not feel comfortable disclosing this diagnosis. So that can be difficult if you're just now realizing this in labor and things like that. So you can't just if you try to just refer someone out, that could cause more harm than good. So that may make the stress levels go up. So this is just something that we kind of have to be able to manage on our own, and then implement a tiered structure. Like if there's a need for a higher level of care, then we can refer out and make sure that the person's comfortable with that. Let's see. And then I want to include the estimates. Okay. So 1 in 3, research, 1 to 3% will develop a new PTSD, and 4 to 5% will experience a recurring trigger for PTSD related to a previous trauma exposure. Another study showed that 6% of people with PTSD related to childbirth and 24% will experience PPMD, which is postpartum mood disorders. There is a difference between PTSD and postpartum mood disorders. They can be experienced together, or they can be experienced separate. Postpartum mood disorder is frequently a result of PTSD, though. The mood disorder occurs at a much higher rate than childbirth-related PTSD. So you could have a perfect birth and not have postpartum mood disorder, or you can have a perfect birth and have a postpartum mood disorder. They're not mutually exclusive. PTSD is a direct relation to trauma, but PMDD is not necessarily related to trauma. It can be just because of a hormonal imbalance. And I think as midwives, we pretty much know that there is a roller coaster of hormones, especially toward the end of pregnancy and after the pregnancy. So that can be a result of a postpartum mood disorder. PTSD can develop into other pregnancy-related comorbidities, such as a low birth weight, premature labor, premature rupture of membranes, the substance abuse, an inability to bond with the infant, all types of things. And then postpartum mood disorders usually screen for after a birth. Therefore, we do have a higher diagnosis of the mood disorders, but not necessarily PTSD. It's not quite as frequently screened for. So as community midwives, we offer like a tiered approach, like I was saying earlier. The first step is to offer a screening tool to everyone. Assume everyone has trauma, whether they do or not. That way you're treating everyone with trauma-informed care. Step 2, you need to have trauma-specific care to individuals based on their needs. This is like creating a care plan or a plan to avoid triggers. So not everyone's trigger is going to be the same. You know, like some people may have PTSD from a previous birth. Some may have a sexual PTSD trauma. There's just so many different types that not everyone's going to have the same triggers, right? So not everyone's going to be triggered by touch. Not everyone's going to be triggered by the feeling of labor and things like that. So everyone can potentially have a different trigger. And so it's up to the midwife and the client to individualize those care plans to make sure that we minimize re-traumatization and avoid those triggers. And then lastly, if all those tactics that you're talked about with, if you've offered some support groups and things like that, then it may be time to step it up a notch to a trauma informed therapist or specialist, and that could help someone. This is kind of somebody that's outside of the midwife scope, but it could help before the birth, after the birth, you know, things like that. So that's definitely a good idea. So, you know, trauma and PTSD affects people of minorities much more frequently, and they're less likely to get the trauma-informed care that they need. A large majority of people that are marginalized already deal with toxic stress and, you know, the effects of that. So that can be detrimental to the baby and the parent. So there's, you know, 3 high-risk populations here in Yuma that we deal with are migrants and non-English speakers, teen pregnancies, and military folks that are pregnant. For migrants and non-English speakers, it can be super helpful to have someone who speaks Spanish, here anyways, at least it's mainly Spanish. And then teenage pregnancies can be challenging because those people are still growing and developing. And then the CDC says that the majority of teenage pregnancies are within Hispanic, Black, Native American, and American Indian. So those are already minorities in themselves. So that's like a double risk factor. So with teenagers, you really just need to be like judgmental. Give them all the education resources that you can give, and just make sure that they have adequate support. If they do not have adequate support, you could encourage some support groups. I know we have some here in Yuma. They're mainly virtual, but we could definitely encourage some of those. And then military folks, you know, they're already dealing with their own trauma, typically, PTSD and things like that. So we have an advocate here that helps with, you know, referrals and adequate prenatal care. And then, you know, because it's important to incorporate all these additional layers for optimal care for minorities, and all the support groups and things like that can only be even more helpful. So, let's see, how to invite and respond to disclosure. So one of the things that I really enjoyed learning about is, you know, when you're asking someone about trauma, if you're doing a screening tool, or, you know, if you're just doing inquiries or anything like that, if they say, I had, yes, I had an abuse as a child. Okay, tell me more about that. And maybe they might not want to tell you more about it right then. And, you need to build that rapport more, and that's fine too. I would just say just make a note of it, and then, maybe come back to it later on when they feel like they can open up a little bit more. You definitely don't want to re-traumatize them by saying, well, I need to know more, anything like that. Storytelling can help in a lot of ways, because the story is not always readily available for them to process or to tell you. It may be an evolution of a story, that comes out over the time spans of the prenatal care. What you see in an intake, like that's written down. Okay, say for instance, they had a birth in a hospital. It was 3 hours long, spontaneous, what you see clinically. It was a spontaneous birth. It was a vaginal birth. There was no tearing. If all of these things that we clinically see as positive things doesn't mean that that wasn't a traumatic birth. And on paper, we could be looking at that, and it's showing us that, like we see, oh wow, that must have been such a great birth. It looked like it was so easy because it was so quick and all this. And actually it was absolutely the opposite. And, when you invite someone to tell that story, then you're letting them open up and like tell it in their own words. And that's, incredibly helpful. You never want to, of course, criticize them or, be aware of your body language and make sure that you're receiving the story well and things like that. Let's see. And obviously you always want, I feel like it's obvious, but maybe not. You always want to ask these stories or, do this storytelling type of situation in a private area where there's like no other people that can hear and things like that. Be an active listener and things like that. So, screening tools and the practice that we use right now, currently we're not using a whole lot. We use an intimate partner violence screening tool. Another one that I really liked was the ACE, the adverse childhood experience, because I just feel like that tells you so much of someone's history that can lead into some of these comorbidities, and allows for all of these screening tools are ways that you can individualize care and create like a safe prenatal and birth plan. So like I said, because it has to be individualized, you have to figure out what's going to make the client feel safe. So for one person, what's going to work for one person isn't going to work for another. And make sure you notate all that so you know what they need. Avoiding triggers. There's a lot of things that midwives have to do or are inclined to do. Exams, asking for position changes, touching, all of those things can be triggers. A way to kind of know if someone's being triggered is they seem fidgety, or maybe they're biting their nails. Crying, of course, would be indicative of potential trigger. So some of the tools that you can use to minimize the trigger is acknowledging that the trigger is happening, encouraging them always to have a safety person, so a person that's there for them, and explain everything that needs to happen and why it needs to happen. And then, always ask questions too. So like if there's something that you feel like they're being bothered by, ask them what's going on and how can I help you? And, of course, if they're pushing, that's not going to be, maybe a time that they'll be able to function enough to answer these questions. But encouraging these conversations before the labor and birth is a great way to do that. And then self-care practices. I get to write a little bit of that down. It's very important for midwives to be aware of their own triggers and be able to manage those. It's really, boundaries can be really hard with midwives. I'm finding that out in a really interesting way. I feel like I always make myself readily available, and I'm going to have to figure out a way to cut back on that. So that's something that we always need to be practicing as midwives. Having debriefs, especially, I mean, after every birth, but especially after something that's somewhat traumatic in itself, being able to debrief with another colleague and things like that, that's just definitely a way of self-care and sustainability. And that's another thing that I think midwives are, have a hard time with, is figuring out a work-life balance and staying sustainable. So in my practice, I'm hoping and like crossing my fingers that I will be able to do 1 month off, 5 months on, 1 month off, 5 months on. That's how I feel like that I will be able to maintain sustainability. So I'm hoping that that was a pretty good tool for an informed midwifery practice, and I want to wrap it up because I know that it's getting pretty long. And I will add my references and resources on another page. Thanks.